Okay, so in the previous classes we had discussed about all other parts of the GIT, including small intestine, large intestine, and inflammatory bowel diseases. In today's class, we are starting with rectum and anal canal. So most of the diseases in your curriculum has been asked from rectum and anal canal. So as much as possible, try to understand it here. Okay. So we'll be dealing with various pathologies related to rectum and anal canal like hemorrhoids, rectal prolapse, fistula in ano, fissure in ano, CA rectum and CA colon, and we'll end the session. Okay. So yeah, starting with hemorrhoids. Before we start with hemorrhoids, we need to know some basic anatomy related to rectum and anal canal. Okay. So what is the length of the anal canal? That is 14 centimeters or 14 yeah, that is 14 centimeters. Okay, and normal ano-rectal angle, that is rectum and anal canal are not in a straight line. It is like rectum is like this, and then it is continuing with anal canal. So this is anal canal and this is rectum, which is at an angle of about 120 degree. So this angle is almost about 120 degree. That is the anorectal angle. Okay, so anorectal angle is about 120 degree. So what I drew was in a cross section. If you see a person from sideways, so rectum, and then it is continuing as anal canal. So this angle is almost 120 degrees. Okay, yeah. And then we need to know about some certain fascias, that is Denon-Miller's fascia is continuing as rectogenital fascia and Walde's fascia is continuing as rectosacral fascia. Okay, other than this, yeah, this is how actually in a cross section you can study the anatomy of rectum and anal canal. So here all we need to know is this, that these columns are called as anal columns. Okay, so whatever I am covering in green, these are called as anal columns and they end in a line which is called as pectinate line. So pectinate line is a line where the anal columns will end. Okay, and then there are two sphincters for the anal canal, one being external anal sphincter and one being internal anal sphincter. So these are the internal anal sphincters, and then this is the external anal sphincter. Okay, external anal sphincters are voluntary, whereas internal anal sphincter are involuntary. And this puborectalis is a muscle which is holding the uh, what we can say anorectal angle. Okay, this is mainly responsible for the anorectal angle. And then there are circular and longitudinal muscles in the rectum, that is always fine. And then this is called as anal sinus. That is, whatever the anal columns are there, they will form anal sinus and then they terminate at a line, and that line is called as pectinate line. Okay, after that we need to know that this is also called as anal valve. After this, yeah, there is a fascia called as perianal fascia, and then it will have an intersphincteric groove between two sphincters, and then at last is the skin. So this can be divided, that is that can be divided into 8 mm, 15 mm and 15 mm, basically 3 and 3.8 centimeters approximately. Okay, yeah, again the same picture. These are the anal columns, these are the anal valves, and then they all terminate at a line called pectinate line, below which again there is a 15 mm gap, and then it opens into skin. Okay, so with this anatomy we'll start with hemorrhoids. Yeah, as we all know, hemorrhoids are nothing but normal anatomical cushions. So basically these are nothing but a vascular support. Okay, these are vessels and they provide support. So whenever these vascular cushions are dilated and they get prolapsed, then that scenario is called as hemorrhoids. Normally, anatomically, these cushions are present in three regions. You can say left lateral, right posterior, and right anterior. So if you are visualizing a patient in lithotomy position, we'll say, and this is the anal canal, suppose. Okay, so this is anterior nerve, and this is posterior, This is left side and this is right side. So these anatomical cushions will be present in, if you imagine this as a clock, 3 o'clock position, 7 o'clock position and 11 o'clock position. Okay, so these three are the normal locations of these anatomical cushions. Hence, if there are hemorrhoids, the location of the hemorrhoids will be commonly seen in 3 o'clock, 7 o'clock and 11 o'clock position. If the vascular cushions come down from these region, then it is called as hemorrhoids, and usually these are seen in these three locations. Okay, so what are these actually made up of anta kelidre? They can be venules, or they can be arterioles, or they can be smooth muscles and elastic tissues. Mainly these are blood vessels. Along with that, there can be elastic as well as smooth muscle fibers. Okay, after this, what exactly causes hemorrhoids? Why does these vascular cushions, whichever are there, they prolapse down or they come down? It is mainly because of excessive straining, and most common cause is constipation or dry feces, we can say. So on constipation, due to excessive straining, what happens? There will be abnormal descent of these anatomical cushions, and this will also lead to injury by hard fecal matter. Okay, and this causes bleeding per rectal. Okay, so basically, because of straining, these are coming down, and because of this hard fecal matter, when they are passing down, these vascular cushions, whatever are there, they are damaged. Okay, because of this reason, there will be bleeding from these vascular cushions, and hence the patient most commonly will present with piles, nothing but bleeding per rectum. Okay, and usually it will be painless. Okay, we'll see why it is painless and when it will be painful and all. Okay, so the most common cause for bleeding per rectum is what we have discussed now, that is hemorrhoids. And the most common significant cause of significant lower GI bleed overall is colonic diverticula. And occult bleed ಅಂದರೆ ಯಾವಾಗಲೂ ಒಂದು ಕಡೆ bleed ಆಗಿದೆ, but it has not come out. It will come out later on. So that is angiodysplasia or vascular ectasia. This is occult bleeding. Significant lower GI bleeding is colonic diverticula. Most common cause of bleeding per rectum is hemorrhoids. Okay. So clinical presentation, how will the patient present to us? He'll usually present with painless bleeding, and the amount of bleeding will be usually 3 to 5 ml and maximum 10 ml a step, not more than that. Along with that, there can be mucosal discharge and all. Okay. Diagnosis, since these are vascular cushions and they cannot be palpated, this is most important. Hemorrhoids cannot be palpated. We cannot identify hemorrhoids on per rectal examination or digital rectal examination. We have to go for proctoscopy. That is an instrument which is used to visualize anal canal, side walls of the anal canal. Okay, so this point is most important. We cannot diagnose hemorrhoids based on digital rectal examination. We have to go for proctoscopy. So what are the types of hemorrhoids? There are two types of hemorrhoids basically. One being internal hemorrhoids, other being external hemorrhoids. So these, where we discuss the anatomy, so there is a dentate line. Okay, if the hemorrhoids occur above the dentate line, that above the dentate line, it is a pain insensitive region, hence there will be painless bleeding. And internal hemorrhoids are most common, hence we just said painless bleeding is the most common. So internal bleeding will occur if these hemorrhoids are above the level of dentate line, and there will be painless bleeding. If it occurs below the level of dentate line, then that is called as external hemorrhoids. And external hemorrhoids have painful bleeding because the nerve supply over there senses pain. Okay, this is also called as 5 days painful self-curing lesion, because ಇದಕ್ಕೆ ಏನು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋದೇ ಬೇಡ. Over 5 days there will be pain, but it will self-resolve or it will cure on its own. Hence it is known as, external hemorrhoids are known as 5 days painful self-curing lesion. Okay, recurrent thrombosis is seen in case of external hemorrhoids, and this leads to semi-ripe black current. Okay, if we see external hemorrhoids, treatment is excision directly. But internal hemorrhoids again can be graded into first degree, second degree, third degree and fourth degree. So treatment for internal hemorrhoids depends on the degree. Okay, we'll see that. So how or what are the degrees of internal hemorrhoids? So internal hemorrhoids, first degree, patient will have only bleeding, that's it. Okay, in the second degree, bleeding will be there and the mucosa of the rectum will prolapse when the patient is defecating. So suppose they have described here. So there is this mucosa which is prolapsing when the patient will be passing stools. After the patient has passed stools, there will be no prolapse. Okay, this is second degree. That is called as spontaneous resolution. While defecating, there will be prolapse, but as soon as the patient completes defecation, there will be a spontaneous resolution. And the third degree being bleeding and prolapse with manual reposition. So spontaneous resolution illa illi. In this case, the patient himself has to push this, whatever the rectum has prolapsed, that he has to push it to its normal position. That is called as manual reposition, and that is third degree internal hemorrhoid. Fourth degree internal hemorrhoid is bleeding and there is permanent prolapse. There is no manual reposition also. The prolapse, whatever has happened, it will stay there itself. That is permanent prolapse. Okay, so these are the degrees of hemorrhoids. Now we will discuss the treatment of internal hemorrhoids according to the degree. In case of first degree hemorrhoids, okay, there is only bleeding. So in this case, usually it is happening because of constipation. So we'll say do some dietary modifications. Don't eat hard foods. Use stool softener. Have high fiber diet and go for sitz bath. Sitz bath is nothing but advise the patient to have lukewarm water. ಅಂದರೆ ಉಗುರು ಬೆಚ್ಚಗಿನ ನೀರು. ಓಕೆ, lukewarm waterನ ಒಂದು ಟಬ್ಬಿಗೆ ಹಾಕ್ಕೊಳ್ಳಿ. Lukewarm water, put it in a tub and sit in this for about 10 to 15 minutes 2 times a day. Okay, this will ensure that the anal sphincters ಏನಿದೆ that will relaxation of anal sphincters, and then it will also ensure hygiene and prevent infections. So relaxation of anal sphincter as well as hygiene. So sitz bath is used, and this is used in the treatment of first degree hemorrhoids and fissures, usually anal fissures. Okay, so in case of first degree and second degree and selected patients of third degree, we can go for banding, sclerotherapy, or both banding and sclerotherapy. Okay, what is this? Banding andre ಏನು? ಇವಾಗ ಬೇಸಿಕಲಿ ಹೆಮೊರಾಯ್ಡ್ಸ್ ಅಂದರೆ ಏನಾಗ್ತದೆ, they have shown here. Suppose, okay, I'll try to draw it. Okay, so suppose these are hemorrhoids. And here is a dentate line, imagine. So I have drawn internal hemorrhoids. Okay, so what we can do is we can use an instrument and then go for banding. They have shown here, yeah. So this is a ligator and they can hold this hemorrhoid, that is a vascular cushion, and put a rubber band like this. That is called as banding. So because of this, what happens, there will be cut off of the blood supply of this region, and this will undergo fibrosis and it will fall off. Okay, so this we have cured internal hemorrhoids. We are holding the internal hemorrhoid, we are putting a rubber band so that whatever this tissue is there, that will lose its blood supply and it will undergo necrosis or fibrosis and it will fall off. This is called as banding. Similarly, sclerotherapy, just like in vascular in varicose veins, how we'll do, we'll inject an agent, that is 5% phenol in almond oil. Because of this sclerosing agent, there will be fibrosis. Same action as like banding, but we are injecting an agent instead of putting a rubber band. Okay, so fibrosis ಆಗುತ್ತೆ, ಅದಾದ್ಮೇಲೆ it will fall off. So this can be done in case of first degree, second degree, as well as some patients of third degree internal hemorrhoids. Okay, in banding, rubber band is applied over the hemorrhoid. After 48 hours, hemorrhoids are sloughed off because of ischemia, and then the lesion heals with fibrosis. Okay, ಇದು ಅರ್ಥ ಆಗಿದೆ ಅಲ್ವಾ? ಸೇಮ್ ಮೆಕ್ಯಾನಿಸಮ್ ವಿಚ್ ಐ ಸೆಡ್. Okay, rest of the third degree patients and fourth degree patients, we have to go for surgery, and that surgery is called as hemorrhoidectomy, that is removal of hemorrhoids. Ectomy and removal. So there are mainly 3 types of hemorrhoidectomy, we can say. That is Millie and Morgan open hemorrhoidectomy, Ferguson closed hemorrhoidectomy, and Longo's stapler hemorrhoidectomy. These are the 3 types, and the other one being Whitefield submucosal hemorrhoidectomy. Okay, usually these closed and submucosal hemorrhoidectomy are not used now. Okay, most common being open hemorrhoidectomy and Longo's stapler hemorrhoidectomy are used. Most preferred method is this stapler hemorrhoidectomy. Okay, because it is associated with less post-op pain. So open hemorrhoidectomy ಅಲ್ಲಿ ಏನು ಮಾಡೋರು, since the most common location was 3 o'clock, 7 o'clock and 11 o'clock, they used to hold this by 3 clamps. Okay, they used to hold the mucosa of the rectum by 3 clamps, and then they used to dissect this so that it would be like madhya cut ಮಾಡಿ ಹಾಕೋರು. So 3 o'clock, 7 o'clock and 11 o'clock, it would have become like this, a circular opening like. Okay, and madhyadalli there was this thing, the mucosa or the connective tissue between these openings must be kept intact. That was a challenge during these surgeries ashte. Okay, basically opening, creating a dissecting this, they used to remove the whatever the vascular cushions were there. That is called as open hemorrhoidectomy. That's it. So in case of stapler hemorrhoidectomy, what they'll do is they'll reach the dentate line, and above the dentate line they'll put a stapler, and then they will pull the whatever the mucosa or whatever these cushions are there, they used to pull it back. So this is basically like folding your arms, whatever, like if you are wearing a full arm shirt, and then you will put a stapler above your elbow and then pull the sleeve above it, above the elbow. Okay, so basically putting a stapler there and then pulling whatever the mucosa is there. So by that, whatever the hemorrhoids were remaining, they used to fall off. Okay, that is a mechanism used in stapler hemorrhoidectomy. Okay, what is the most common complication in case of hemorrhoidectomy is most commonly pain and urinary retention. Yeah, this was about hemorrhoids. Okay, ಇದರಲ್ಲಿ ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ? Okay, we'll move forward then. Next disease being rectal prolapse. Okay, rectal prolapse is again of two types, that is mucosal rectal prolapse or full thickness rectal prolapse. In case of children it will be mucosal, in case of adults it will be full thickness rectal prolapse. So what are the exact causes, or what are the main causes for rectal prolapse? Andre protein energy malnutrition, worm infestation, diarrhea. Basically, yeah, everything, these all will cause diarrhea, and if there is excessive diarrhea, there will be increased risk for rectal prolapse. Other than that, there can be sacral agenesis or meningomyocele, which are rare causes, that is neural tube defects. These can also cause rectal prolapse. Okay, how will we manage a case of rectal prolapse? So it depends on the cause. Conservative management for common causes like what we had discussed here. Protein energy malnutrition idre adakke takkange calories kottu we can treat. If there is worm infestation, we can treat the worm infestation by albendazole or anything. Diarrhea adre diarrhea treat ಮಾಡಬೇಕು. So these, by treating this, we can go for conservative management. If the patient is not responding to this conservative management, then we'll have to go for Lockhart mammary rectopexy. Pexy ಅಂದರೆ ಯಾವುದಾದ್ರು ಒಂದು ಬೋನಿ ಸೆಗ್ಮೆಂಟ್ಗೆ we will tie this rectum. Okay, so basically sacropexy, rectopexy, ಇದೆಲ್ಲ ಪ್ರೊಲ್ಯಾಪ್ಸ್ ಕೇಸಸಲ್ಲಿ ಲೈಕ್ ವೆಜನಲ್ ಪ್ರೊಲ್ಯಾಪ್ಸ್ ಆಗಿರ್ಬೋದು, ರೆಕ್ಟಲ್ ಪ್ರೊಲ್ಯಾಪ್ಸ್ ಆಗಿರ್ಬೋದು. ಇನ್ ದೀಸ್ ಕೇಸಸ್ ವಿಲ್ ಯೂಸ್ ದಿಸ್ ಪೆಕ್ಸೀಸ್. ಓಕೆ, ಸೊ Lockhart mammary rectopexy, we will whatever the rectum has prolapsed down, we will pull it up and we will tie it with a suture to some bony segment. Okay, that is the surgery done here. For rare causes, we will have to go for Thier's anal wiring. Okay, for adults, rectopexy via abdominal approach can be done or via perineal approach. So rectopexy via abdominal approach ಆದರೆ there is decreased recurrence rate because there will be a good surgical site, so we can easily visualize it and do a proper surgery. In case of perineal approach, there is not much proper space available for the surgery, hence there is increased recurrence rate. But abdominal surgery via abdominal approach, there is increased morbidity, whereas perineal approach there is low morbidity. Okay, preferred in young patients. Abdominal approach recurrence ಆಗಬಾರ್ದು, ಇನ್ನು ಲಾಂಗ್ ಲೈಫ್ ಇರುತ್ತೆ, ಮತ್ತೆ ರಿಕರ್ ಆದರೆ ಈ ಕಾಂಟ್ ಅಂಡರ್ಗೋ ಸರ್ಜರಿ ಅಗೇನ್ ಆ್ಯಂಡ್ ಅಗೇನ್. ಸೊ ಫಾರ್ ದ್ಯಾಟ್ ರೀಸನ್ this abdominal approach is preferred in young patients, whereas in old patients and frail patients we can go for perineal approach. So what are the types of rectopexy? That is Wells rectopexy or abdominal rectopexy or Ripstein rectopexy. In perineal approach, there can be perineal or Altmaier or DeLong. These are basically named surgeries. Okay, so resection rectopexy is Goldman-Freiberg. That is, whatever the part of rectum has prolapsed, we will take off that rectum and do the surgery. That is Goldman-Freiberg resection rectopexy. And if it is not treated with any of these treatments, then we will have to go for thier's anal wiring. Okay, this was about rectal prolapse. So we discussed about the two types, causes, management in case of adults. Okay, then coming to anorectal abscess. Okay, so anorectal abscess ಅಂದ್ರೆ ಏನಾಗುತ್ತೆ basically. So we can see in this diagram that there is anal columns and anal sinuses, which we had studied earlier also. Anal column which will form anal sinuses. Suppose if there is infection here in this anal column or anal sinuses, it can spread to perineal region, perianal region, and then that will lead to formation of an abscess which is called as anorectal abscess. Okay, it is most commonly due to E. coli or Bacteroides fragilis. These are the two organisms mainly responsible for infection, which will in turn lead to anorectal abscess. So based on the location, we can say there are four types of anorectal abscesses, mainly perianal abscess, and then ischiorectal, which is the second most common, and then submucosal or pelvirectal. Okay, this can reach up to suprauretal region. So based on the location, perianal is the most common because it is nearest to anal column. Okay, so formation of anorectal abscesses, there will be opening of anal glands at this dentate line or crypt of Morgagni. Okay, so basically anal column ನಾನು ಆವಾಗಲೇ ತೋರಿಸಿದ್ನಲ್ಲ, it will be like this. So this, whatever the depression is there, they are called as crypts of Morgagni, and this is called as anal column. Okay, so there will be opening of the glands in this region. Via the crypts, infection reaches the anal gland, and then there is pus formation and it follows the path of least resistance. So whatever the pus formation happens, that will be collected in the perianal area, and that causes perianal abscess. So basically ಈ ಡಿಪ್ರೆಷನ್ನ ಕ್ರಿಪ್ಟ್ ಅಂತ ಕರಿತೀವಿ, ಎಂಟೈರ್ ಥಿಂಗ್ನ ಏನಲ್ ಕಾಲಮ್ ಅಂತ ಕರಿತೀವಿ. ಇಲ್ಲಿ ಗ್ಲ್ಯಾಂಡ್ಸ್ ಓಪನ್ ಆಗ್ತಿರುತ್ತೆ, ಏನಲ್ ಗ್ಲ್ಯಾಂಡ್ಸ್. ಸೊ ಈ ಗ್ಲ್ಯಾಂಡ್ಸಿಂದ ಏನೇನು ಸೆಕ್ರೇಷನ್ಸ್ ಬರುತ್ತೆ, ದೇ ವಿಲ್ ಬಿ ಇನ್ ದಿಸ್, ಆರ್ ಬೇಸಿಕಲಿ ಏನಲ್ ಗ್ಲ್ಯಾಂಡ್ಸ್ ಆರ್ ಓಪನಿಂಗ್ ಇನ್ ದಿಸ್ ಕ್ರಿಪ್ಟ್ಸ್. ಸೊ ಈ ಕ್ರಿಪ್ಟ್ಸಿಂದ ಏನಾದರೂ ಇನ್ಫೆಕ್ಷನ್ ಆದರೆ that will split to gland, hence this is called as cryptoglandular theory. Okay, crypt in the glands ಗೆ infection spread ಆಗ್ತಿರೋದನ್ನ cryptoglandular theory ಅಂತ ಕರೀತಾರೆ. And once this infection spreads, what happens after the infection spreads, there will be pus formation, and this pus will reach the perianal region, and then it will lead to abscess. So hence called perianal abscess. Okay, it is a tract behind, or basically a U-shaped tract in the ischiorectal fossa, forming the ischiorectal abscess. So once this perianal abscess happens, then it can lead to, or it can spread to ischioanal fossa or ischiorectal fossa, and then it can cause ischioanal abscess. Okay, yeah, the theory responsible for formation of anorectal abscess is called as cryptoglandular theory. Okay, so ಇವಾಗ abscess ಆಯಿತು, anorectal abscess formation ಆಗಿದೆ. What will be the clinical features? How will the patient come to us? He will be in severe pain because abscess ಇದೆ ಅಲ್ಲಿ. Obviously infection ಆಗಿದೆ, so because of that reason he will be having fever also, and there will be swelling in this region because of collection, and then there will be swinging pyrexia, that is fever with chills and rigors ಇರುತ್ತೆ usually. Okay, so how will we treat? We will have to go for abscess ಇದ್ರೆ ಏನು ಮಾಡ್ತೀವಿ, ಇನ್ಸಿಷನ್ ಆ್ಯಂಡ್ ಡ್ರೈನೇಜ್. ಸೊ ವಾಟ್ ಇಸ್ ದ ಟೈಪ್ ಆಫ್ ಇನ್ಸಿಷನ್ ವಿಲ್ ಡೂ ಹಿಯರ್ ಇಸ್ ಕ್ರೂಷಿಯೇಟ್ ಶೇಪ್ಡ್, ಅಂದರೆ ಸ್ಟಾರ್ ಶೇಪ್ಡ್ ಇನ್ಸಿಷನ್. ಸೊ ದೇ ಹ್ಯಾವ್ ಶೋನ್ ಹಿಯರ್ ಅಲ್ಲ, ಸ್ಟಾರ್ ಶೇಪ್ಡ್ ಇನ್ಸಿಷನ್ ಹಾಕ್ತೀವಿ. ಆಲ್ ದ ವಾಟ್ ಎವರ್ ದ ಆಬ್ಸೆಸ್ ಹ್ಯಾಸ್ ಬೀನ್ ಕಲೆಕ್ಟೆಡ್, ದ್ಯಾಟ್ ವಿಲ್ ಬಿ ಡ್ರೈನ್ಡ್ ಆಫ್, ಆ್ಯಂಡ್ ದೆನ್ ಫಾರ್ ಇನ್ಫೆಕ್ಷನ್ ವಿಲ್ ಗಿವ್ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್. ಇಷ್ಟೇ ಟ್ರೀಟ್ಮೆಂಟ್. ಓಕೆ ಅಲ್ಲ. ಸೊ ಮೇನ್ ಥಿಂಗ್ ಅಬೌಟ್ anorectal abscess is how is the abscess happening, why is it happening? Because of crypts, and then these crypts will have anal glands opening over there. Because of infection in the crypts, it will spread to glands, and from there it will spread to perianal region or ischiorectal fossa, or it can spread above the ureter also, and that is called as supraureteral. Okay, so this was about anorectal abscess. Then coming to fistula in ano. Okay, so what do we know about fistula? Fistula or sinus is nothing but it is a blind opening in the anal canal. Okay, so this is a chronic abnormal communication between the anorectum and the outside, that is perineal skin. Okay, history of anorectal abscess or anorectal sepsis will be present in these patients. So basically you can say fistula in ano is a complication of anorectal abscess. Okay, if the abscess has happened and the patient hasn't come to you and you have not treated, then what happens, the whatever the collection is there, that will try to find a route to escape out. Okay, in that route there will be formation of a abnormal connection between the perineal skin and the anorectum, and that is known as fistula in ano. Okay, so this forms a tract outside known as fistula in ano, and the theory responsible again is same for anorectal abscess again itto ade cryptoglandular theory. Okay, now we need to know components of the ano-rectal ring. Okay, that is fuborectalis. So if you can see in the diagram I have drawn here, so this is the fuborectalis, which is forming a sling like thing which is pulling this rectum. So because of this reason there is a fuborectal angle of 120 degree, and other than that this ano-rectal ring involves internal anal sphincters and external anal sphincter. Okay, so internal anal sphincter, external anal sphincter. Imagine you are seeing the person from the side. So first you will get externally external anal sphincter, and then internal anal sphincter, and then anal canal. Okay, so this internal anal sphincter is formed by inner circular layer of muscles, whereas external anal sphincter is formed by outer longitudinal layer of muscles. Okay, based on this you can say the types of fistula in ano. There can be low lying fistula if the internal opening of the fistula is below the ano-rectal ring. So this is the ano-rectal ring. Okay, if the fistula is opening below this ring, okay, then it is called as low lying. So illelindano open aagta idre fistula, then it is called as low lying. Okay, if it is opening above the ano-rectal ring, it is called as high lying fistula. Simple fistula andre single straight tract idre, complex fistula andre multiple branched tract. Okay, so here you can see this is simple andre onde ಒಂದು simple straight fistula ide. In this case it is complex because it has multiple branches and multiple fistulas are there. So these are the types of fistula. You can say high lying and low lying, and simple and complex fistula. Okay, what is the exact cause for this fistula in ano? Just like we discussed, it is because of cryptoglandular theory, that is ano-rectal abscess. Other than that, there can be Crohn's disease, because of which there is ulceration bandu perforation agutte. Again, whatever the secretions are there, they will come out through the fistula. Other than that, it can be a sexually transmitted disease like athwa genital ulcer disease, that is lymphogranuloma venerum. Okay, other than that, it can be fungal infection, actinomycosis, or foreign body in the rectum, which can again lead to disrupting the mucosa of the rectum and anal canal, and finally leading to fistula. Other than that, again ulceration ಏನೇನು cause ಮಾಡುತ್ತವೆಲ್ಲ, malignancy or HIV, these all can cause fistula in ano. What will be the clinical features? Usually this fistula in ano is more commonly seen in males and in the 30 to 50 year age group, 3rd to 5th decade. Okay, there will be intermittent purulent discharge and pain in the anal canal. If the patient passes feces and flatus from the external opening, if the patient passes feces and flatus from the external opening, likely position of internal opening is in rectum. Okay, so if the patient is able to pass feces and flatus anta andre, then where will be the opening of the internal this fistula? Ivaga ಎರಡು opening ಇರುತ್ತಲ್ವಾ, ಒಂದು external opening, that is in the perineal skin. Okay, that is external opening. So we can estimate the internal opening. If the patient is able to pass feces and flatus andre, then it is in the rectum anta, anal canal ಅಲ್ಲಿ ಇಲ್ಲ. If it is in the anal canal, then the patient won't be able to pass feces and flatus. Okay, so that is the point they had to make here. Okay, so what are the key points we should assess in case of a fistula? One, we have to assess the location of internal opening. Where is the internal opening actually? And assess the location of external opening and the course of the tract, whether it is simple fistula or a complex fistula, high lying, low lying, ಇದನ್ನು assess ಮಾಡ್ತೀವಿ. After that we are assessing secondary extension is present or not. Okay. Then complicating disease or condition that can affect healing of fistula, this we should diagnose. If it is happening because of ano-rectal abscess or a Crohn's disease or any malignancy or HIV, this should be found out. Okay, how will we identify this? This is by investigation called as fistulogram, by which we can visualize the fistula, or we can also go for MRI to see the fistula. Okay, so there is a classification given for fistula in ano called as Park's classification. What does this say? This says about the tract of the fistula. Okay, type 1 andre if this fistula is in between two sphincters, hence it is called as intersphincteric, that is between external anal sphincter and internal anal sphincter. So I had drew ala. So if this is rectum, then internal anal sphincter and then external anal. If the fistula is in between these two, it is intersphincteric. Type 2 that is transsphincteric. So one sphincter na cross ಮಾಡುತ್ತೆ. It can be like this. Suprasphincteric ಅಂದರೆ above the level of sphincter, and type 4 is extrasphincteric. Okay, so these are the types. On digital rectal examination, induration around the internal opening can be localized. So this is in case of fistula in ano. Okay, on proctoscopy what we'll be able to see, internal anal opening can be localized if the internal anal opening is, or internal opening of the fistula is within the 10 cm of the anal verge, because that's how much we can visualize. If there the internal opening is in the anal canal itself, like if it is here, we will be visualizing from here, we will be able to see the internal opening on proctoscopy. Okay, there is a rule called Goodsall's rule in case of fistula in ano. This is very important. What does this rule say? To indicate the likely position of the internal opening on the basis of external opening, we are using this rule. So basically we are knowing opening of the external opening of the fistula, we know. We are now estimating or to indicate the likely position ಯಾವ್ದು ಇರಬಹುದು ಅಂತ ಗೆಸ್ ಮಾಡೋಕ್ಕೆ ಒಂದು ರೂಲ್ ಕೊಟ್ಟಿದ್ದಾರೆ. That rule is Goodsall's rule. What does this say? If the external opening is located anteriorly, these are joined by short straight track. Okay, for example, if it is in the 11 o'clock position, external opening is in the 11 o'clock position, then the internal opening will also be in the 11 o'clock position anta. ಅಂದರೆ ಸಿಂಪಲ್ ಸ್ಟ್ರೈಟ್ ಇರುತ್ತೆ ಆಂಟೀರಿಯರ್ ಅಲ್ಲಿ ಫಿಸ್ಟುಲಾ ಎಕ್ಸ್ಟರ್ನಲ್ ಓಪನಿಂಗ್ ಇದೆ ಅಂದರೆ. ಇಫ್ ದ ಎಕ್ಸ್ಟರ್ನಲ್ ಓಪನಿಂಗ್ ಆರ್ ಲೊಕೇಟೆಡ್ ಪೋಸ್ಟೀರಿಯರ್ಲಿ, then these are joined by long curved track and opens in the posterior midline. Okay, so that is if the in the posteriorly located external openings, whatever may be the position of the external opening, posteriorly ಎಲ್ಲಾದರೂ ಆಗಿರಲಿ, internal opening will be at 6 o'clock position ಅಂತ. So imagine you are looking at the anal canal. Okay, if this is the external opening in the anterior region, then internal opening, if I draw it 3-dimensionally, so this is anal canal anta ankondre, so it will be having a straight tract and the internal opening will be anteriorly and this will be a straight tract. Okay, if the external opening is in the posterior region, then there will be two long tracts and the internal opening is also at 6 o'clock position ಅಂದರೆ ಈ ರೀಜನ್ಗೆ. ಸೊ ಎಕ್ಸ್ಟರ್ನಲ್ ಏನಲ್ ಓಪನಿಂಗ್ ಪೋಸ್ಟೀರಿಯರ್ ಇದ್ದರೆ ಇಟ್ ವಿಲ್ ಆಲ್ವೇಸ್ ಗೋ ಆ್ಯಂಡ್ ಜಾಯಿನ್ internal anal opening at or internal opening of the fistula at 6 o'clock position. So this is what this Goodsall's rule says. Okay, but there are two exceptions. That is, one, if the external anal opening is situated more than 3 cm from the anal verge, in that case we can't apply this rule. And if there are multiple external openings, ಅಂದರೆ ಒಂದೇ ಒಂದು ಫಿಸ್ಟುಲಾ ಇಲ್ಲ, ಮೋರ್ ದೆನ್ ಒನ್ ಅಥವಾ ಕಾಂಪ್ಲೆಕ್ಸ್ ಫಿಸ್ಟುಲಾ ಇದ್ದರೆ ದಿಸ್ ರೂಲ್ ಕೆನಾಟ್ ಬಿ ಅಪ್ಲೈಡ್. ಓಕೆ, ದಿಸ್ ಇಸ್ ವಾಟ್ ದ ಸೈಡ್. ಅಗೈನ್ ಪೋಸ್ಟೀರಿಯರ್ಲಿ ಇದೆ ಅಂತ ಅಂದ್ಕೊಂಡ್ರೆ ಎಕ್ಸ್ಟರ್ನಲ್ ಏನಲ್ ಓಪನಿಂಗ್, ಇಟ್ ವಿಲ್ ಬಿ ಇನ್ ದ posterior region only. If it is anterior, there will be straight. Okay, so what is the treatment for fistula in ano? fistulotomy, that is the incision over the fistula tract. Fistulectomy andre excision of the fistula tract. Or we can go for set-on or video assisted anal fistula treatment, or we can just put a glue. Okay, so what is this? What is this set-on? Set-on is a thread which is made up of silk, linen, nylon or elastic. Basically four type of materials can be used, and these can be cutting set-on, non-cutting set-on, marking set-on and staging set-on. What is a cutting set-on andre? Cutting set-on is inserted over the fistula and tied and knot is applied. So basically ಈ fistula tract ಹಿಂಗಿದೆ ಅಂತ ಅನ್ಕೊಂಡ್ರೆ, this set-on is inserted inside the fistula. This is nothing but a thread like thing. Okay, this is inserted over the fistula, and then this is tied and knot is applied. Every week this knot is made tight. Okay, and hence it starts cutting the tissues. Hence this is called as cutting set-on. ಇದನ್ನ ಬೇಸಿಕಲಿ ಟೈ ಮಾಡಿರ್ತಾರೆ ಈ ಥರ. ಎವ್ರಿ ವೀಕ್ ಯು ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಟೈಟ್ನಿಂಗ್ ದಿಸ್ ಟೈ. Okay, so because of this reason there will be cutting of these tissues. So cut ಆಗ್ತಾ it will heal on its own. So hence we have basically fistula ಏನಂದ್ರೆ it is communication from inside to outside. We are cutting the connection by putting this thread like material and tying the knot. That is the main logic behind this. Okay, so using cutting set-ons converts high lying fistula to low lying fistula. Hence we are using set-ons in cases of, yeah, go on.
So don't you think the infection is not contained like this and chances of spread increase if you go on cutting the fistula?
Yeah, we are not exactly treating the infection over here. We are just doing the treatment for fistula. Okay, we are not treating the cause. We are just treating what has caused. Like ಇವಾಗ ಫಿಸ್ಟುಲಾ ಆಗಿದೆ, ಫಸ್ಟ್ ಫಿಸ್ಟುಲಾ ಟ್ರೀಟ್ ಮಾಡೋಣ, ಆಮೇಲೆ ಅದಕ್ಕೆ ಏನು ಕಾಸ್ ಇತ್ತು ಅದನ್ನು ನೋಡ್ಕೊಳ್ಳೋಣ, ಆ ಥರ. ಓಕೆ, ಫಿಸ್ಟುಲಾ ಇಸ್ ಬೇಸಿಕಲಿ ಜಸ್ಟ್ ಲೈಕ್ ಅ ಓಪನಿಂಗ್ ಅಷ್ಟೇ, ಒಂದು ಚಾನಲ್ ಥರ. ಸೊ ಫಸ್ಟ್ ಚಾನಲ್ ಬ್ಲಾಕ್ ಮಾಡಿ ಆಮೇಲೆ ಅದಕ್ಕೆ ಏನು ಕಾಸ್ ಆಗಿತ್ತು ಅದನ್ನು ಟ್ರೀಟ್ ಮಾಡ್ತೀವಿ. ಓಕೆ ಅಲ್ಲ?
But it is lined by unhealthy granulation most of the time that can increase the infection,
Yeah.
as per my understanding. So could you please elaborate that, please?
Sure, yeah. So yeah, this actually is a treatment for fistula. Okay, ನಾನು ಹೇಳ್ದಂಗೆ ಅದೇನೆ. So infection part, yeah, what will we do for infection? If there is an infection, what are you going to do? You are just going to give antibiotics ಅಷ್ಟೇ. So along with this treatment they will be treating with antibiotics. But now for closure of fistula, what we are doing, we can go for fistulotomy, that is putting an incision over the fistula tract, or fistulectomy, removal, that is excision of the fistula tract, whatever is there, that one. Otherwise the treatment is this, like we put a thread like material made up of silk or linen or elastic. These again, yeah, just like you said, it is made up of some unhealthy granulation tissue. There can be an infection already, but for that again treatment is just antibiotics ಅಷ್ಟೇ.
Okay, sir. Thank you.
Yeah. Uses cutting set-on converts high lying fistula into low lying fistula. Basically you are closing the fistula, putting it lower down. Okay, because of this reason there will be treatment of high lying fistula is associated with high risk of fecal incontinence. Okay, so when are we supposed to use set-on actually? So treatment of complex ano-rectal fistula, that is there are more than one opening, external opening. In that case we can use set-on so that we will block the pathways. So ಇವಾಗ ಈ ಥರ ಹೆಂಗೆಂಗೋ ಓಪನ್ ಆಗಿರುತ್ತೆ, ಅಲ್ಟಿಮೇಟ್ಲಿ ಇಟ್ ವಿಲ್ ಬಿ ಹ್ಯಾವಿಂಗ್ ಒನ್ ಎಕ್ಸ್ಟರ್ನಲ್ ಏನಲ್ ಓಪನಿಂಗ್ ಆರ್ ಎಕ್ಸ್ಟರ್ನಲ್ ಓಪನಿಂಗ್, ಇಂಟರ್ನಲ್ ಓಪನಿಂಗ್. ಸೊ ವಿಲ್ ಪುಟ್ ಅ ಸೆಟ್-ಆನ್ ಆ್ಯಂಡ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಕಟಿಂಗ್ ದೀಸ್ ಟಿಶ್ಯೂಸ್ lower down so that we can convert these complex fistulas into simple ano-rectal fistulas, and then we can treat it. So treatment of fistula in case of Crohn's disease and HIV patients, again we can use this set-ons. Draining set-on is used in case of draining set-on is used to control infections as they have multiple infectious fistulas. So yeah, just like I have said, there are various types of set-ons. Cutting set-on irbodu, ಅದೇ ಥರ non-cutting set-on. Just we'll put the set-on and we will insert a tube into that. So basically like this, we have inserted a set-on till here, and from here we are using a drain so that infection whatever is there, it is contained and it will drain out. Okay, and there are some other types of in case of anterior fistulas also we can use cetons, and anterior fistulas are usually common in females. So other than this, we can use cetons to treat for chronic diarrheal state, fistulas associated with chronic diarrheal state. Okay, so this was about management of fistula in ano. So fistula in ano is an important topic, hence we have discussed it over some time, I guess. Okay. Related to ceton, there can be infection while we are cutting the tissue, and for that we will just treat it with antibiotics, nothing else. But there is a risk of fecal incontinence. Okay. So next we are starting with fissure in ano. Fissure in ano is nothing but a wound in the anal canal, you can say, or a breach in the epithelium, or just an ulcer like thing. Okay, that is nothing but you can say discontinuity in the epithelium of the anal canal. Okay, discontinued epithelium in the anal canal is called as fissure in ano. So usually, what is the location of the dental line? It is 2 centimeter from the below the anal verge. Okay, so longitudinal split in the anoderm, that is from the anal verge to the dental line, that is called as fissure in ano. So suppose this is the dentate line, and then this is the anal verge, that is 2 centimeter, and then there is a longitudinal split. It is nothing but a cut like this, longitudinal cut, that is called as fissure in ano. So location usually in the posterior midline at 6 o'clock position, these fissures are seen. Okay, these fissures can be again of two types, acute fissure or chronic fissure, based on duration which from which the fissure has happened. So if it has happened recently, acute fissures. If it is there from a long time, chronic fissures. And the chronic fissures, whichever are there, they are characterized by a triad called as cano-shaped ulcer or small boat-shaped ulcer, then sentinel pile, also called as skin tag. So basically skin tag ಅಂದರೆ it will be like ಈ ನರಗುಳ್ಳ ಅಂತ ಹೇಳ್ತೀವಲ್ಲ ಆ ಥರ ಹೆಂಗೆ ಎದ್ದಿರುತ್ತೆ, that sentinel skin tags will be there in the anal canal ಅಥವಾ external opening, anal opening ಹತ್ರ. So if these skin tags are there, they indicate that this is a chronic fissure. Okay, sentinel pile. And then hypertrophied papilla, if it is there, that indicates it is a chronic fissure. Okay, so what is the pathophysiology here? Usually because of this fissure there will be spasm of the anal sphincter, that is internal anal sphincter, which is involuntary anal sphincter. Patients will have, what will have because of spasm? Patients will have constipation. Patient is unable to pass stools because the sphincter is not relaxing. Because of this reason there will be excessive straining again. So during excessive straining, at the time of defecation, the fecal matter passing through this internal anal sphincter, suppose if it opens, then there will be injury to the pain sensitive mucosa of the anal canal. Okay, this will lead to tear or split in the anoderm, basically forceful opening of the internal anal sphincter. Because of defecation there is tear, and that has caused decreased vascularity, which has led to impaired healing of the this tear. Okay, ಬೇಸಿಕಲಿ ಒಂದು ಗಾಯ ಆಗಿದೆ. ಆ ಗಾಯ ಯಾಕೆ ಆಗಿದೆ ಅಂತ ಕೇಳಿದರೆ ಬಿಕಾಸ್ ಆಫ್ ಫೋರ್ಸ್ಫುಲ್ ಡಿಫಿಕೇಶನ್ ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ, ಆರ್ ಬಿಕಾಸ್ ಆಫ್ ಹಾರ್ಡ್ ಸ್ಟೂಲ್ಸ್, ವಾಟ್ ಎವರ್ ಮೇಟ್ ಬಿ ದೇರ್, that will in turn cause fissure in ano. Principle of treatment is basically relaxing this spasm of the internal anal sphincter. Okay, fissure in ano is similar to achalasia cardia. Okay, achalasia cardiadalli ಏನಾಗ್ತಿತ್ತು, lower esophageal sphincter has contracted completely and it is not relaxing because of absence of some ganglion cells ಅಲ್ವಾ, inhibitory cells absent ಇತ್ತು ಆ ರೀಸನಲ್ಲಿ. So because of that reason there was contraction and it was not relaxing. Similarly here internal anal sphincter has contracted and it is not relaxing because of some spasm. There can be multiple causes for this spasm. Okay, because of this reason there is inability to pass stools. That doesn't mean absence. So what the patient will do, or what the person will do, he will forcefully try to defecate, and when he is trying to defecate forcefully there will be a tear in this epithelium, and that is called as fissure in ano. So what will be the clinical features? Severe pain during defecation. If there is involvement of vessels in this region, again streaking of blood over stools. In fissure in ano, digital rectal examination is contraindicated because excruciating pain ಇರುತ್ತೆ, ಕಾಲಲ್ಲಿ ಓದಿತಾನೆ ಅಷ್ಟೇ ಹಾಗೆ ಡಿಜಿಟಲ್ ರೆಕ್ಟಲ್ ಎಕ್ಸಾಮಿನೇಷನ್ ಮಾಡುವಾಗ. ಸೊ ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ರೀಸನ್ ಫಿಶರ್ ಇನ್ ಏನೋ ಅಲ್ಲಿ digital rectal examination or parrectal examination is contraindicated. Similarly, we have to examine the gluteal region, find the longitudinal split in case of posterior midline, because this is the most common region, 6 o'clock position. Okay, so after we have diagnosed fissure in ano, how are we going to treat it? So treatment is basically initially conservative management, because tumba pain irutte, we can't do anything. We'll advise the patient to go home, sit in lukewarm water for about 10 minutes 2 times a day. That is called as sitz bath. Okay, and this will relax the internal anal sphincter. Steam ತಗೊಳ್ಳೋದಲ್ಲ, he has to sit. Okay, internal anal sphincter. Okay, and we can advise stool softener so that there won't be much straining during defecation, and pain will be reduced. Okay, other than that, we can give medical treatment same like achalasia cardia, which will relax the contracted or muscle spasm. That is calcium channel blockers like 2% diltiazem gel for local application, and nitrates can be used, or botox injection again into the sphincters can be given. This will relax the spasm of the internal anal sphincter. Other than that, there is a procedure called as Lord's procedure, where we will manually dilate the internal anal sphincter, and this is not performed usually. Then treatment of choice for fissure in ano banbiಟ್ಟು, it is Notaras lateral sphincterectomy. That is divide the internal anal sphincter laterally. So ಇವಾಗ internal anal sphincter ಹಿಂಗಿದೆ ಅಂದರೆ one side you divide it so that it will become like this. Okay, because of this reason now the spasm will be relieved, and you can also treat it with anal advancement flap. So this is about fissure in ano. Okay, next one being pilonidal sinus. Again, sinus is nothing but a single blind opening, whereas fistula is nothing but communication between two sides. Okay, so fistula has two openings, whereas sinus has just one opening. It is a single blind opening wherever it can happen. So hence pilonidal sinus will have only one opening, and it is blind. This is an acquired condition usually seen in hairy males. Okay, and usually among 20 to 29 years. Common in military personnel and jeep drivers. So hence it is also called as jeep driver disease. ಯಾಕೆ jeep driver ಅಲ್ಲಿ ಕಾಮನ್ ಅಂದರೆ, ಬಿಕಾಸ್ ಆಫ್ ಸಪೋಸ್ ಇವಾಗ ಪೇಷಂಟ್ ಹ್ಯಾಸ್ ಮೆನಿ ಹೇರ್ಸ್ ಇನ್ ದ anal region. Okay, and he sits for a long time. Military personnel or jeep driver, he sits on these hairs. So whatever these hair are there, ಇವಾಗ ಏನಾಗುತ್ತೆ, those hairs will be like this. Okay, so ಹೆಂಗೆ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡೋದು, I'll see. Okay, so hairs are arising because these hairs, suppose if they are like this, they will be turning backwards over there. So wherever these hairs are opening, because of constant pressure, like he is sitting for a longer time, jeep driver ಎಲ್ಲ ಗಂಟೆ ಗಟ್ಟಲೆ ಕುತ್ಕೊಂಡು ಗಾಡಿ ಓಡಿಸ್ತಾ ಇರ್ತಾರೆ, because of that reason wherever this hair is ಅಥವಾ open the other end of the hair is there, that will be poking ಅಲ್ಲ, there will be a formation of this sinus. So because of hairs this is happening, and that is called as pilonidal sinus. Most commonly seen in jeep drivers, hence the name jeep drivers disease. ಆಯಿತಾ, collection of dead hair in the natal cleft overlying the coccyx is usually seen. Clinical feature ಏನಿರುತ್ತೆ, basically discomfort in the postnatal cleft region with intermittent serous discharge. ಸೊ ಅಲ್ಲಿ ಆ ಹೇರ್ಸ್ ಎಲ್ಲ ಓಪನ್ ಆಗುತ್ತೆ, ಅಲ್ಲಿಗೆ ಹೋಗಿ there will be a formation of a sinus, and there will be discharge which will be watery. ಸೀರಸ್ ಡಿಸ್ಚಾರ್ಜ್ ಶುರುವಾಗುತ್ತೆ, ವಿಚ್ ವಿಲ್ ಬಿ ಇಂಟರ್ಮಿಟೆಂಟ್. ಅವಾಗವಾಗ ಅಂದರೆ ಸ್ವೆಟ್ಟಿಂಗ್ ಥರ ಅಂದ್ಕೊಳ್ಳಿ, ಎಲ್ಲ ಟೈಮು ಸ್ವೆಟ್ ಆಗ್ತಿರಲ್ಲ, ವಿಲ್ ಬಿ ಸ್ವೆಟ್ಟಿಂಗ್ ಓನ್ಲಿ ಸರ್ಟನ್ ಟೈಮ್ಸ್. ಸೊ ಇಂಟರ್ಮಿಟೆಂಟ್ ಇರುತ್ತೆ, ಸೀರಸ್ ಡಿಸ್ಚಾರ್ಜ್ ಇರುತ್ತೆ. ಆ್ಯಂಡ್ ದೆನ್ ಇಫ್ ಇಟ್ ಗೆಟ್ಸ್ ಇನ್ಫೆಕ್ಟೆಡ್ ಓವರ್ ದಟ್, ಇಟ್ ಕ್ಯಾನ್ ಲೀಡ್ ಟು ಫಾರ್ಮೇಷನ್ ಆಫ್ ಅನ್ ಆಬ್ಸೆಸ್. ಓಕೆ, ಯೂಶಲಿ ದ ಲೊಕೇಶನ್ ಈಸ್ ಇಂಟರ್ಡಿಜಿಟಲ್ ಪೈಲೋನಿಡಲ್ ಸೈನಸ್, ಕಾಮನ್ಲಿ ಸೀನ್ ಇನ್ ಬಾರ್ಬರ್ಸ್. ಸೊ ಬಾರ್ಬರ್ಸಲ್ಲಿ ಆರ್ಮ್ಸಲ್ಲಿ ಕೂಡ ಆಗ್ಬೋದು, ಹ್ಯಾಂಡ್ಸ್. ಓಕೆ, ಬಿಟ್ವೀನ್ ದ ಡಿಜಿಟ್ಸ್ ಆಫ್ ದ ಹ್ಯಾಂಡ್ಸ್. So basically hairs get accumulated in barbers between these region, and usually they'll not wash, or they'll won't maintain proper hygiene, and because of that reason there will be accumulation of hairs in this region, and then it will lead to pilonidal sinus. And it can be seen in region of umbilicus also and axilla also. So basically ಎಲ್ಲೆಲ್ಲಿ hairs ಇರುತ್ತೆ ಆ region-ಅಲ್ಲಿ it is most common. Okay, so pubic region or umbilical or axilla or interdigital pilonidal sinus in case of barbers. How will we manage? If it has led to the formation of abscess, we'll go for incision and drainage, and because infection agide adrindaನೆ abscess agide, for that reason we'll go for antibiotics. If there is no abscess, then if we are able to see the sinus tract, excise it and closure of defect using some flap. Okay, so flaps used for closure is Limburg's flap or Kargyadski's flap. Okay, okay. After this is basically Limburg's flap ಅಂದರೆ ರಾಂಬಾಯ್ಡ್ ಫ್ಲಾಪ್ ಅಂತ ಇವಾಗ ಹೆಂಗೆ ಹೇಳ್ಬೋದು ಅಂದರೆ ಯಾ ಇಮ್ಯಾಜಿನ್. ಸೊ ಇಲ್ಲೊಂದು ಸೈನಸ್ ಆಗಿದೆ. ವಾಟ್ ದೇ ವಿಲ್ ಡೂ ಇಸ್ ದೇ ವಿಲ್ ಎಕ್ಸೈಸ್ ದಿಸ್ ಎಂಟೈರ್ ಪಾರ್ಟ್. ಸೊ ಎಕ್ಸೇಷನ್ ಆಯಿತು. ಆಫ್ಟರ್ ದಿಸ್ ಫ್ರಮ್ ಸಮ್ವೇರ್ ದೇ ವಿಲ್ ಟೇಕ್ ಅ ಫ್ಲಾಪ್ ಇನ್ ದಿಸ್ ಶೇಪ್ or from rhomboid major, you can say, from a muscle, and they'll suture it. This is like taking a tissue from somewhere else with vascular supply. Flap andre it will have tissue and it will have its own blood supply. So that flap is put here and this tract will be closed. Okay, excision of the tract and closure along with some flap. So this is the treatment for pyloneedal sinus. You can also perform a procedure called as Bascom procedure at Bekilla. So this flap under abscess agidre incision and drainage. If there is no abscess, excision of the tract and closure of the defect using a flap. This is the treatment for pyloneedal sinus. Okay, I guess only two more diseases are remaining in rectum and anal canal, that is CA rectum and CA anal canal, which will take a long time. So we'll discuss this in next class.